Hello, good morning, Saleh. Are you able
Good
to hear me?
morning. Good morning.
Assalamu
Yes, we can. We hear you. Wa alaikum assalam wa rahmatullahi wa barakatuh.
Okay, so the floor is yours. You can walk us
Okay,
through
thank you.
your thought process and the case, and we have the panelists over here, and we're going to discuss and see you perform. So,
Sure. Thank you, Ayman, for this kind introduction, and I'd like to thank the organizing committee for having us.
sorry, Saleh,
We are
I think we
delighted.
have some difficulty hearing you. There's a lot of echoing.
Do you hear us now? You hear me?
There is some difficulty in hearing you.
Assalamu alaikum.
Are you able to hear me, Saleh?
لتعلي صوت, maybe you raise your voice and
Assalamu alaikum. Do you hear me?
a little bit better. Okay, move on.
Okay, thank you, Ayman, for this kind introduction. And I would like to thank the organizing committee for having us. We are delighted to present a case from Makkah, King Abdullah Medical City. And let me introduce the team first. My co-operator, one of the senior intervention and structural consultant, Dr. Abdullah Gabashi. We have our cardiac anesthesia, Dr. Majdi, also the rest of the team, Sam, Rambo, Bayan, and Tasneem. Shall we go with the presentation?
Yes, please.
With all the panelists. Can we have the slides? Are you seeing the slides, Dr. Ayman?
Well, the slides, no. Now we see your slides, the TAVI case.
And do you hear us clearly?
Okay, so we have this case. Can you go next slide, Abdullah? Rashmi. 65-year-old male patient, diabetic, hypertensive. Patient had chronic anemia and history of spine disc prolapse, causing him limited mobility. And he's the kind of patient that refuses any surgical intervention, even for his disc problems. He presented with heart failure symptoms in October and had an ECG with right bundle branch block. His echo showed severe aortic stenosis, as you can see here, with an aortic 5 mean gradient of 46 and a peak grade of 87. Can you go next? His QRS is about 140 milliseconds, and he's a right bundle branch block. Next, please. This is his echo. He got good ejection fraction, he got mild aortic regurgitation, and as you can see, there is a gradient, as I mentioned, 46 mean. Go next, please. And it's a tri-leaflet valve with rather mild to moderate calcification only. Next. This coronary angiogram showed mild coronary artery disease. Can you play the angiogram? Only mild coronary artery disease, some diffuse atherosclerotic LAD dystole, and no other significant disease. Next. So the case was discussed in our heart team discussion meeting, and he was accepted for transcath aortic valve implantation. Go next, please. We did the CT TAVI, and you can see that the area here is, the perimeter is 79.8, and the annulus dimension 23 by 27, and an average of 25. Next. Actually, next, not the slide. Go back to the slide, because there is 4 components of the slides. Yeah. And the LVOT is very similar in perimeter to the annulus, not a big difference. Can you show the next part of the slide? Go back, Abdullah, to the original slide. Go back. Yeah, keep that slide on. And the sinuses are big, 36, 31, and 33. And as you can see, the calcification is not that much. Go next. And the coronary height is also good. The left main is about 16 millimeter, and the RCA is about 18 millimeter. And we have our coronary angle. The peripheral vessels also is excellent. Both sides are good size with no atherosclerotic disease. Go next, Abdullah. Next. Okay. So, which valve and which plan should we go with? Can I leave you with that discussion, Ayman? And you tell us what would
I think
you
that's a good
go
time
with
for
that?
us to interject over here. So the floor is open here, Dr. Turki, Dr. Muhammad. I think here is kind of clear, severely stenosis the aortic valve. I think all platforms here may be reasonable to tackle. What's your take? From the echo appears to be tricuspid.
Thank you, Abdullah. Thank you, Saleh. A nice case, but I couldn't figure out, is it bicuspid or tricuspid? And the
Can
reason
you
is
go back
that
into the echo?
in the
Can you show him
CT,
the echo?
in the CT you showed, I can't figure out two sinuses. So there is not a lot of calcium. So at the age of the patient, so I was thinking, is it a bicuspid? Could it be a bicuspid?
Next picture. Well, actually, it was clear that it's tricuspid. You can see the echo here. Can you see it? And also in the CT, maybe, I don't know if the image didn't project. There is partial fusion of some of the leaflet, but not complete. So I think it's a tricuspid valve, but it just stenosis and mainly fibrotic, most likely, rather than calcification.
Okay, so now the second important question is the existence of right bundle branch block. So the age of the patient, the pathology, the lack of calcium, it's not too much calcium. You are sure that it is tricuspid, but there is a right bundle branch block. So that's certainly an important component when you want to choose the valve. And the coronaries are normal, but his young age. So I would say that if you are asking me what type of valve you'll go for, I will say a short frame, and I will stop at this stage, you see. So I need a short frame valves to access the coronary. Ideally, I need something which caps the leaflets and secure the access to the coronary better, but short frame will be fine. I need a valve which has the least conduction abnormality, because there is already, he's young, and there is already a right bundle branch block. So I will go into the least valve which has conduction abnormality, but at the same time has the least likelihood of paravalvular leak. So might be sort of complex, but I would say short frame, and probably majority will do of short frame will do this.
Great.
Okay, we'll take your point, Dr. Attardi. How about the other panelists? Do they think the same, or anybody with the long frame, for example?
Sorry, say that again?
Or anybody with other type of valve other than what Dr. Attardi is in favor of?
Dr. Faisal, you have a quick comment? I think I concur with Dr. Muhammad about in these cases that we face more and more in the younger population. I think you have to keep an eye on the long term and keeping an access to your coronaries, because these patients will develop coronary disease and will come back to us, and we need to really be able to tackle their problems. Dr. Bender, if you want to have a quick comment, and after that we'll have you proceed with your plan, and we'll discuss as we go.
Yeah, actually, as you see, this patient is very young, 65 years old. So as Dr. Muhammad, we have to address all these important steps. But the other thing also, your future management for this TAVI valve. We know this TAVI valve will require maybe another valve in the future. So you have to select the appropriate platform which will give you the best result in the future. I think this anatomy, it can be suitable for all type of valves, and every valve have its own unique features. But I think the problem is the future plan for the future valve.
Great. I think these are the points that we have. If you can show us, and we'll...
Those are excellent points. If we can go to the next slide after we said what is the plan and so on, and then we'll show you what. So we've chosen a self-expandable valve. relatively a long frame type of valve, but with good access to coronaries, given the height of the coronaries that is pre-existing in this patient. Can you show them the next slide? Yeah. So that's what we chose, actually. Can you go next? So as you see that the arches will allow good access to the coronaries, and the height of the coronaries is helping us in that. And it's personally, I feel that the right bundle branch block problem might be better with this valve. Go next. And we have projected simulation also for lifetime management of this patient. And we depicted that we can put a balloon expandable valve inside this valve without any problem. VTC is nice and the height is nice as well. So this is a balloon expandable valve inside it, maybe in 10 years time or whatever. So why don't we tell you about our plan and the choice of the valve. So Dr. Saleh will explain to you what we've done so far and how we are planning the procedure.
Great. So we're going transfemoral axis, right side for the valve, accurate new to large size 27. We will do a pre-dilatation with a 23 millimeter balloon. And after the valve deployment, we're going to assess the valve expansion. And if needed, we're going to post-dill with a 25 millimeter balloon. We will obtain commissural alignment. And we had a temporary pacemaker from the left femoral vein. Usually we tend to use single axis for the femoral axis and the right radial or left radial for the pigtail injection. However, the patient has no good radials. Minimalistic approach, sedation, conscious sedation. And we have our pigtail in the non-coronary cusp. Can you show us the fluoroscopic images, please? Can you go on flow?
Can you see the images, the fluoroscopy and hemodynamics?
You can just focus on the live performance and just lose the slides for now, and we can.
Yeah, take the slide off.
Yeah,
Abdullah,
that's much better
take
now.
the slide off. Thank you. Yeah.
Good.
Okay, so we have the pigtail in the non-coronary cusp. This is our coplanar angle, and our safari wire is across the aortic valve into the LV. So we'll proceed with pre-dilatation now with a 23 millimeter crystal balloon.
We have a comment from Dr. Weil. Please.
So Dr. Saleh and Abdullah, all the best. Just a quick question. Do you use routinely the sapphire wire? And if yes, do you have all the sizes of the safari wire? What's your preference?
Well, I think all the wires very much equal. Maybe there is preference of some people one over another. Safari wire is a good one. It can go nicely in the apex, and I prefer it personally. Unless we have supplies issue, then it will be a problem. But we can work with any wire really.
That's good. Maybe we can take the thoughts. What do you think about the pre-dilatation as a step?
Pace at 180.
I think it's quick and easy sometimes, but
Pacing,
it's
180.
in the way. What's your thoughts, takes?
Yeah, I think it's important if there is bicuspid, but I will be very careful in pre-dilatation if you choose accurate new. I'll be very careful. And the reason is the radial strength on the lower part of the valve. We know it has a low radial force compared to the other self-expanding. So there might be an issue of paravalvular leak. So I will be towards the minor axis, comparing it to the LVUT, and maybe I will go even 1 millimeter lower when I have to pre-dilate if my choice is accurate new. That's, I think, important point.
Absolutely. Dr. Faisal, you have a comment.
Thank you. Not to distract the operating team, but great job for a team in Mecca. But I think the choice of valve here, as Dr. Mohammed alluded to, the patient decided to refuse surgery, so we are giving him the best available chance with the lifetime. The question to the team, I know the perimeter is in the
Can you
radio,
raise your voice because your voice is far away?
but there is no downside to upgrading. You have a generous annulus, and if you are really thinking about lifetime management, I would have personally picked large in this specific scenario. You choose wisely.
You pick what, sorry?
the
I can't hear you,
accurate
yeah.
for balloon expandable, because clearly you see a horizontal aorta that is also playing in the factor. So I think good luck with the team, but I would have said medium. I would favor large because even that will increase
No,
the
no,
chances
the-
of
you mean the
balloon
size of the
expandable
valve?
for larger size in the future.
You're talking about the same valve,
Good
or
point. While you want to follow up on that?
Just
we
following
didn't get you. Sorry, we couldn't hear your voice.
Faisal?
You're talking, Faisal, about the size of the accurate new, or what?
Yeah, Dr. Faisal is saying you can use large because there, rather than medium, because there is a
But
generous.
it is large. It is large, actually.
We're
It's
going
not
with a
medium.
large valve.
We're going with a large valve.
Yeah.
It's not medium.
So for me, this is a good choice for lifetime management. This is one of the beauty of this valve is you can easily do valve and valve in the future. And they claim also that it is a bit expandable if you use, like the radial force example of Mayval or Edward. It can increase up to 2.5 millimeter. And all the best, Saleh.
Okay. Actually, this valve is a large valve. It's not medium. I don't know if you saw it written somewhere medium, but it's large actually, not medium. And as you said, any valve can do in this anatomy in particular. We believe that we will use this valve as a better choice.
Okay, now we're going to obtain commercial alignment. The site port was 6 o'clock from the beginning. Now we are at the coplanar angle.
So
We want to see the...
commissurally, if you can push the picture a little bit.
Okay.
Commissurally, I think we just need a little bit of a clockwise there.
So we need to see both free cells equal from both sides in that coplanar angle.
Okay. That doesn't look bad here.
I think you want to pay attention to the pigtail, maybe
Yes,
the,
Yeah, I think
We'll
it
adjust
slipped
it.
into the non-coronary
the
cusp,
right
probably.
coronary sinus.
So we'll get it back into the... let us just get... Okay.
Let's go to the cusp overlap.
Looks better there.
So for the moderator, would you choose different valve, or you are okay with the choice of Dr. Saleh?
I think let them finish and then we can discuss.
Okay, so we have it here very
they're in
nicely
a tricky
aligned. You
spot
can
now,
see that
so-
the fetal now is in the right side. Okay? So we are very happy we can dive in with this valve now.
Go back to coplanar angle.
Feel free.
You're doing great, Saleh, but you need to pay attention to the pre-shaped wire. You don't need to push it too much against the apex.
Thanks.
Yeah, I
That's
think we still
correct.
a little bit.
Yeah, always an issue when there is a horizontal aorta, so you have to take
Yeah,
your
it's not horizontal,
time.
actually.
Take your
The
time,
degree
yes.
is over 60.
I'm sure Abdullah is watching the wire.
Yeah.
And there is a marker. You will make benefit of the marker.
Okay, so we need to go a little bit more.
The beauty of this valve is the arches. You start up and you come down. But
Yeah.
Ready for
Okay.
sync?
Sini?
And the trackability of...
So, question to Dr. Bandar and Ahmed. Are you okay? Like, how many platforms you want to have at your center? Or, like,
We're actually happy
what
about
is your
the
dream?
position.
What's your dream and what is
guys?
the reality?
Okay.
We will start releasing the first bit of the valve. We are
Okay,
happy
so
about
actually
that
we are
position.
lucky here in Saudi Arabia that we have the majority of all the platform in Saudi Arabia is available. But each center, in my personal opinion, I don't think so that every center should have all the platform. Every platform have its unique feature, but I think in the majority of the case it can be done
Okay,
by
we
2
need
or
to- we
3
need to proceed,
platform
guys.
if it is available in
We
our
need
center.
to,
So I was
deliver the valve now,
like
okay?
some of the center
Can you
in
hear
Canada
me?
they are doing more than 350 cases and they have only 2 platform. So
We'll
for me,
deploy
for
the valve
myself,
now.
and also my young colleague, which they are starting doing TAVI, I think try to master 1 or 2 a platform, and in case you have specific advantage of one platform over the other, you can ask one of your colleagues to help you with that. So in PSCC, actually, we have like 3 to 4 platform, and I think in the majority of time we are using 2 of them.
Okay, we'll start releasing the valve here. So I'm going slow now.
We're watching you carefully. You're doing a great job. Pretty horizontal aorta.
Just a comment to the team, there is no penalty
So the upper
when you
crowns
finally release to use rapid pacing.
are
So
appearing
in fact,
now.
I start to use rapid pacing a lot when you come to the
And
final
interesting.
spot.
Let's take a cine.
As you can see,
A little bit high.
a little bit higher.
We need to push it in. And let's start pacing, please, at 120.
Actually, there was a lot of movement and there is septal hypertrophy that might be playing a role as well.
Pace at 120, please.
120 only. In a little bit.
Rapid pacing and
Go 140, please. Okay.
Okay, because we don't want to lose the
making
leaflet
dynamics a
as
bit.
well. So we are fine there. Okay, we'll continue releasing. Okay, so we will take,
Inject.
you're releasing now.
Stop
stop
pacing.
pacing.
I think it's too long pacing. Are you?
No, we stop.
Are we ready to inject?
Ready to inject?
Yeah, inject. In a good spot.
What do you think of that?
You have a good position, and the anchors actually you anchor the leaflet, but you just want to maintain your. I think to me it looks beautiful.
Okay, we are maintaining our position.
Back to pacing,
So-
please, 140.
I think it's a good spot over there.
Okay, we'll start release.
Good.
Okay, stop pacing.
Great.
Thanks. Now we are pulling the wire backwards to centralize the nose cone. Now push the wire.
Be careful when you release the pigtail.
No, we will do it with the wire actually.
Yeah.
Yeah, take the wire. You might need to post dilate. So
We'll see now. We'll talk about the post-dilate.
this is important, Abdullah Saleh, because we know that the lower frame has a low radial force. So be careful when you remove the pigtail, please.
Just
Right,
a
good.
quick question. That's a great Saleh, mashallah, tabarakallah. So this wire, especially this valve, you have to remove the balloon with wire. Yeah, definitely you have to remove the wire. I have a question, Dr. Faisal Abdullah. After we finish the cases in the cath lab, we see there is, for example, mild paravalvular leak. But you guys, the echo people, you reported moderate plus 3+. Do you think that being the flow across or near a metallic objects, it increase the, do something with the Doppler, the Nesquik, or what you call it, exaggerating the mild, make it moderate? Is it like, I think it's common in our practice.
That's correct. We see a lot of paravalvular leaks, especially after TAVI. Most of the time, we give them like a follow-up echocardiography, and most of these cases will resolve or at least will decrease. Now, regarding how much or how can we decide the severity of the disease, there are a lot of things we look at. The pressure half time, we look at how much is the width of the jet, But there are no specific, it's not like the typical AI, it's not like the native AI. When it comes from a paravalvular leak, we look at many things in imaging and also in the patient's symptoms. There are a lot of things that can decide the severity of the disease. But definitely paravalvular leak is a very common. Most of the time they resolve with most of the platforms, especially the self-expandables. And I think measuring the severity is a hassle and a difficulty, but we give the patient time and then we can decide.
Safe flow.
Definitely, time factor is important. Maybe I'll ask. We have a surgeon with us, and so with the cases that you see that get complicated with infective endocarditis, do you feel and you operated on it quite a bit? So, do you feel any platform is easier, or is it the same, or explain to them it's a?
You know what? We will not ask you about infective endocarditis because we know you are an amazing surgeon. So, extracting a valve.
That's the question. How would you?
That is the question. Extracting a valve.
The answer is clear. They have the same incidence of endocarditis. The problem that the surgeon, they hate the long frame. So the low frame is very easy. Explant is a bad thing if you are pushed to do it, but it becomes a disaster sometimes when there is a long frame.
22 carbon.
Now, if I want to comment on the cases that we have seen, infective endocarditis and TAVR valves, all the cases that I have removed the valves were balloon expandable cases. I haven't removed any self-expandable valve yet. And the longer the stent, the more difficult the valve to be removed. And the smaller the root as well is the more difficult the valve to be removed. So some of the cases I have operated on, they have large roots, and the removal was done without the need to replace the whole root. And we just replaced the valve, and it was an easy case. But the cases that the valve was inserted in a small root, we ended up replacing the whole root, and it was a major surgery, and the patient was septic. And these are the cases that you don't want to do and you don't want to deal with. And some of these cases, you may want to expose the patient to longer courses of antibiotic before taking them to surgery. And all the cases that we have done also, they had a paravalvular leak. So maybe the paravalvular leak is involved in the pathogenesis or the origin of endocarditis. So I would have to say maybe small roots, patients with paravalvular leak has more incidence of infective endocarditis, especially balloon expandable valves. I mean self-expandable valves, not balloon expandable.
So Abdullah, Saleh, what's your assessment now?
We
don't see a leak.
Look at the two pictures we took. So can we show you the previous picture, dry staining before? Yeah, this one. So this is dry staining in the coplanar angle. And look at the valve and tell us what you think, whether it's expanded or not. And I will show you the other view as well that we took. Go next view. Next. This view, without the contrast, the one before.
Abdullah, we need to hear you. Can you please just speak louder, please? Sorry for that.
Okay.
We have a technical issue.
We finished the deployment, and we gave you the two pictures after the deployment. So I want you to look at the valve and to see what you think. So we'll show you the picture. So did you see this one? Show the previous one. This one. So look at the valve. Do you think it's well expanded or not? Go next. This one. Look at it again. This is expanded well or not? Go next. This one with the picture.
I think it's expanded well. I don't see on angio any paravalvular leak. I am happy to see the diastolic pressure of 71, while you started with 60, 62, now 71. This is another indication that there is no paravalvular leak. I usually pass pigtail over the pre-shaped wire, and I get direct systolic assessment of gradient, and then I calculate the I index just to be on the safe side. And if there is echo in the room, it would be perfect to do transthoracic quick echo. but I like
That
the
looked good,
result.
Ali. You
Great
happy with that?
result. Thank you very much, Dr. Saleh from Mecca.
No.
We enjoyed your presentation, the
Just
exciting
quick question.
discussion. I think
I think it'll work really well,
Pointing that it's ended. Thank you for the panelists. Great presentation, Dr. Adel Taish, and we move on.